Next slide.
You want to hook yours up or just give it a run?
I'm just going to talk real quick.
Okay.
They won't even see me.
Oh, they're not going to see you?
Yeah. So I'd like to introduce Dr. Dan Dunwoody, board-certified orthodontist from Atlanta, Georgia. Dr. Dunwoody will be speaking today on how chronic airway obstruction affects the teeth and face. Thank you so much.
Thank you, Alan. Glad to be here with y'all today. And we're going to just have a little experience here. I'm going to share my observations from about 35 years of just looking at a quest to try to understand how chronic airway obstruction affects the teeth and face. You might ask, well, how did an orthodontist get interested in that so long ago, back when Ronald Reagan was president? Well, my adventures began in the 1980s, where technology was changing quickly, information was spreading quickly, the PC was just being invented, and European doctors were sharing their information with us. This information enabled the American doctor to move beyond the malocclusion and the facial balance as it existed, and to move more into a biologic basis where we could manipulate biologic systems to improve overall facial growth and development in combination with our traditional appliances. Unfortunately, or fortunately really for the times, in order to do this, the nasopharyngeal airway had to be open, or the muscles would not respond properly and affect the bones and the growth of the face. So join me, if you will, on my quest. I'll try to give you the essence of what I've learned and take you on just a quick visit through the face, growth, and nasal airway obstruction. Come join me. The first place we want to look is really with our patients. So we're going to start here. This patient has a lot to learn. By the way, each of these patients you'll see in the first part of this presentation were sent to me for crooked teeth. None of them were sent to me for airway problems. The first little girl is a friend's granddaughter, one of my colleagues' wife's friends. I'm going to point a little bit here to kind of show you a few things about her. Well, I'll have to let you look. If you look at her face, then you'll see that her lips are real dry and cracked. You'll see big allergic shiners beneath where the eyes would be. And that's her pose when she's at rest. That's what her teeth look like. Over here on the side, you may see her teeth, and you can see what a mess they are. You can see that she's got anterior cross bites, posterior cross bites. She's got many other issues there. So, but the underlying factor here is she has sleep apnea. Her nose is stopped up from enlarged turbinates. She has enlarged adenoids and tonsils. The poor child can't breathe. The cracked lips are from mouth breathing and the mother's attempt to keep the airway open using antihistamines and steroids. We'll come back to her later. Here's the next one. You'll see this is a totally different looking face. This is kind of a shorter face. And if you look very closely at her teeth, you'll see this is a broad smile for her. She only shows about 40% of her teeth. And you can look at the kind of mess that she's got going on there. This little girl has enlarged turbinates. And her face, instead of growing vertically and growing as it should, is actually growing shorter as she grows. Here's more of a normal shaped face, and looks pretty good just glancing at her. Again, you've got the dry lips, keratin, and everything else going on. And if you look closely, you'll see that the incisors, upper incisors, are retroclined. And look a little more closely, and you'll see there's an open bite posteriorly. This little girl has nasal obstruction and enlarged tonsils. Here's a good one for you. This is enlarged tonsils and adenoids and nasal structure and a more tapering face. And this girl's been going a long time. I should have seen her a long time ago instead of when she came to the office. If you look at her anterior gingiva, you'll see that it hangs down a long ways when she smiles. You probably see 6 or 7 millimeters of it. The tooth on the left, the canine, her right canine, is actually the one that is in the best place. Everything else has been distorted by the airway problem. You'll see that she has retrocline incisors, and she also has cross bites in 2 places. Here's one of my buddies that I've seen for a long time and I still keep up with, although he's been out of treatment for many years. Look closely here again. Look at his face. You're going to see that the nostrils are very narrow. You're going to see how far his teeth protrude, enlarged buccal corridors, and overjet of approximately 9 to 10 millimeters. The mandible is captured by the lower lip, which again is very dry and in between the teeth much of the time. Then here's a different sort of problem. This gal has sleep apnea. She has skeletal problems. The midface and the maxilla is reclusive. Also, the mandible is prognathic and off to one side. So she's got it all. And she arrived in the office at about 13 and a half to 14. And you can see there what kind of a malocclusion it is. Again, she was sent for her teeth, but she almost can't breathe at all at night. So here's one of my aha moments here. When back in the day, this was about when we were looking at them. Again, Ronald Reagan's president, ET has just arrived. The empire has struck back. John Travolta is out there with all of his movies. And this doctor, this is 1979, Dr. Harville did some experiments on rhesus monkeys. And a rhesus monkey has to breathe through his nose. But he's one of the best models for experimentation. And this is a classic study. But this study caught my attention. And from there, I was hooked with one other little caveat, which I'll share with you after this. So let's look at the rhesus monkeys. They're going to have their noses progressively stopped up so that they can show what happens in the mouth for nasal obstruction. It takes 3 years to do this so that the monkey would survive. Let's go to the monkeys here, because you're going to see these monkeys. You're going to see their pictures in there. You're going to see them in your patients. I started to see them in mine. This just shows you kind of what they look like in general before they started. That's normal over on the far side. And then as you can see the adaptation that the bodies have made over 3 years with the tongue in order for them to breathe. One of them stuck his tongue forward. One of them made a little V in the tongue. The muscles adapted. And the other one on the side, he created what I call a volcano. It's almost an inverted V. But by God, the bodies were going to figure out a way to change and alter so they could breathe. So let's look. Here's one monkey opened his mouth real rhythmically. If you look at the next monkey, look at his lip. Look how V-shaped it is. The lip actually retracted so that he would have a better open airway. Right next to his picture, this is 6 months after the plugs were removed. Now the lip has regained its normal length. Pretty amazing, huh? Now, on the far side here, I hope you can see that. Then you can see that you see a monkey that his teeth kind of move forward, so his lip got in between everything, and it produced a dual bite. Which brings me to the next point. The tooth adaptation remained after the nasal airway was open. So six months later, after the plugs were removed, the lips and tongue were normal. The malocclusion was retained. For those of us who love occlusion and are familiar with Pankey, Dawson, Spear, Coyce, take a look at this. And we'll look closely at these pictures. The one on the far side is maximum intercuspation, which means the place where the monkey chews the most. But if he really bites into something hard and hits centric relation and initial occlusion, now we have a whole different problem. Now the bite's wide open. Normal is on the far side right here. So basically the airway problem caused the canines to elongate and created a dual bite that was retained even after the airway was open. The bones were modified by the musculature in order to breathe, and the teeth were moved. And when the airway was open, the teeth remained where they were, continuing to create the body sensation to the nerves and the muscles that there was an airway obstruction there. So if you ever wonder why maybe you could have a dual bite, this is probably one reason. So the good news, over the 6 months after the plugs are removed, is that the muscles of facial expression and lips, tongue regain their balance. The physiologic balance probably improved also. Now for the bad news. The remaining neural feedback loops that contributed to the malocclusion, created the bony remodeling, still remain. They continue to contribute to excessive tone and size of the masticatory muscles and a constricted oropharyngeal volume and nasopharyngeal volume. So even though the plugs are removed and the monkey can breathe, the upper airway resistance still remains. When I started practice, we were dipping x-rays. And I used both of these x-rays for years so that I could kind of piece together in my mind what I was looking at by looking through and imagining. If you look at the lateral self on the far side, you'll notice the big tonsils. You can see the adenoids. And on the other side, you can see a little bit of a deviated septum. And you'll also see turbinates that are moved. The other image that we're all familiar with is called a Panorex. The Panorex illustrates, again, you can see the tonsils, you can see a little bit of the nose, you can see the bulbous nasal septum, you can see the condyles, you can see the teeth, everything's there. But before the advent of CBCT, the practitioner had to imagine where this three-dimensional anatomy was. Now, not only can we visualize it and see it, but we can measure it. A huge step forward for our patients. So here we are today. I'm fortunate to have the 9600 in my office with a low radiation, the best possible image. And I just look back over the times where all we had was dipped x-rays, varying color, varying everything. And here we are today with something where you not only can you visualize it as far as the bony structures go, but you can also visualize the volumes in the pharynx. And you can measure them. This is huge. And why is it huge? These are images that Dr. Damon gave me earlier, much earlier in about 2013. And if you look at the one on the left, you'll see that the airway looks about like a straw. Well, he used a mandibular advancing device, a Hurst, which is one of the dentofacial orthopedic devices, and he see how much was open. It's like the difference between breathing between two straws and breathing through the garden hose. Myself, I prefer the garden hose. So the module, if you can see around me, really does a lot to help the patient and help them understand where the problems are and what the volume of air can get through there. And using just flow dynamics, then you can visualize what's happening with the fluids. So what is a nasopharyngeal airway mouth? What does it do? It's just one volume. It's just like a big balloon. And it's got the hard palate, floor of the nose is in between them. It only has 4 valves. The purpose of it is just to provide energy for the body. You know, the nose, oxygen, CO2, food for the mouth. That is the only way we get energy unless you're getting an IV drip. Diaphragmatic breathing, that also came along with these changes. The reason diaphragmatic breathing is so important is it establishes a pressure within the chest cavity that enables better blood flow, better breathing, and also helps your immune system work better. In someone with airway obstruction, they take little short breaths and they work the neck and the back muscles, and this part of their life is compromised. But where are we with nasopharyngeal airway? What does it do? We smell, we uptake oxygen, we exhale CO2, but the big thing is the nose is clean. It's a filter. It warms, it humidifies, and it sterilizes. In the maxillary and paranasal sinuses, nitric oxide is actually secreted in a healthy person, and it'll act as a disinfectant. Keeps everybody healthy. It also acts as a vasodilator, which keeps the circulatory system working better and your respiratory system working better. So the nose is pretty important that it be open. So as a dentist, what do? I'm going to be looking at the throat and the oropharynx. So let's see. This information comes from the anesthesiologist literature, and you probably are familiar with it. It's common sense. Anyone who would be difficult to intubate is probably more susceptible to airway problems, particularly if they're overweight. Being overweight changes everything. So the bigger the tonsils, the more the problem. The more the tongue occupies the mouth, the bigger the problem, the less you can see the oropharyngeal opening. And then where's your tongue? As I began this quest, I began looking at throats probably 35 years ago. And now with the advent of lights and loops, I look at the inside of the nose. So that's one of my latest adventures. Let's talk a little bit about growth and what should be going on. As the face grows, the arch should expand and the face should expand and change while growth goes on. And it does in a healthy person. The vertical dimension, if you'll kind of look at the shape of the faces and the heads as we go along, a lot of the growth occurs in the vertical plane and not in the others. So there's incremental change in the transverse anterior-posterior, but the vertical continues to change. Some of it from growth of the brain. Here's one of the little metrics that I've come up with over the years that I hope will be helpful for you in your practice. And if you would just take a look here at the blue arrow, and you'll see that I've measured from mesolingual cusp to mesolingual cusp at the gingiva and come up with a metric of about 30 millimeters. If your child or your adult patient is less than that, there's a good chance they've got an airway problem unless they're extremely petite. So take that and work with it. Know when you're a growing patient, if you write that down, the next time they come in, you should be able to see a change in growth if you use a Bowley gauge. Back to our friend here again with sleep apnea and all the issues. Let's look at the occlusal views now. One of the most common findings in someone with an airway problem is the posterior maxilla develops very poorly, and the maxillary first molars are rotated mesially. That's usually one of the first teeth that come in. That establishes your vertical, and it creates an interference in the back. It constricts the posterior envelope of function, which in turn increases the size and tone of the masticatory closing muscles. As you go forward in this child, you'll see, and I think she has sleep apnea. You'll see the anterior teeth are really turned around in the incisors, and also there's also a crossbite there. Look closely at the lower. It's most unusual to see erosion of this extent in a young patient. So she's got gastric reflux too. So the airway is creating such a suction that when she lays down at night, the contents of the stomach are being sucked up into the oral cavity. She's got failing health. So as we learn about growth, we need to remember the growth only occurs at night, and the teeth only erupt at night. So the question all of us need to answer is for ourselves and continue to ask ourselves, So what happens to children that have sleep disturbances? Well, all of their physiologic systems are in distress. What we see oftentimes is just the teeth, but they are in distress in every system of their body. Sleep apnea, the numbers are somewhere between 2 and 8%. CDC says 2 to 3.7. So let's take a little adventure here. For each one of y'all, I'd like for you to take a deep breath. I'm going to take one. I'm going to exhale. I'm going to close my lips just for a minute. And then we'll have, and I'll ask you to keep yours closed after exhaling. And then I want you to pinch your nose before you draw in another breath and swallow 3 to 4 times. When you do this, you're going to feel that your ears pop. That suction in there, that negative pressure is what shapes and misshapes the bones and teeth and set all of these problems into motion. So, it's a silent remodeler. People don't know it's there. That negative pressure that you felt just remodels everything. The bones, the teeth, the orophacial anatomy, and then all of a sudden your breathing's different, your circulatory system's having to work harder. And a child, sometimes you don't sleep at night, you're sleepy during the day, you've got behavioral issues. There are many issues that come from this situation. So let's look again at just kind of how it works. So once you have airway obstruction, the pressure you felt there constricts the maxilla, which changes the tooth position. Once the tooth position is changed and the bone is remodeled, then you have less room for the tongue to fit in there. Your oropharyngeal volume is decreased. And the teeth begin to move in such a way so that all you can do really is chew straight up and down. So your posterior and anterior envelopes of occlusion are constricted. So guess what? The tone of the muscles increase, and now you have to work harder to eat and to breathe. But the malposed teeth are just a symptom of the problem. Here's a little fun diagram here. Kind of talks a little bit about airway. Everything's happy when you can breathe right. And the teeth work great, the muscles, the bones, joints, growth is favorable. But if your airway's a little stopped up, then the teeth and mouth start being affected. And they work on the muscles, which in turn work on the bones. Then the joints have to adapt. And now the health has to adapt. So with chronic airway obstruction, we're like an apneic or someone who has to breathe through their mouth all the time. The whole system goes into disarray, and you end up with poor physiologic response and poor general health. So the treatment goals for my patients, and I think for most of my colleagues' patients, are, hey, let's open up those airways. Let's increase oropharyngeal volume. Using expansive techniques where we can. Can't always use them, but most of the time you can. Let's make sure the teeth are in a good enough place where they're not interfering with the anterior envelope of function or the posterior envelope of function. Let's shoot for an optimal bite. Let's try to make CR and CO repeatable where we can. Let's make sure our musculature is healthy and comfortable. Bicuspid extractions, working within the biologic framework as opposed to working within the malocclusion, should no longer be needed on a routine basis. There will be times where it will be the treatment of choice, but those will be few and far between. Timing of referral is important. So when do you refer? The more severe the problem and the dental problem, then the sooner you refer. Remember, girls mature faster than boys. So we want to get the somatic maturity as well as the dental maturity. So the initial exam is still recommended when the first molars and the upper and lower incisors are in. Do not wait on the permanent teeth. You may miss a great opportunity. So, if the malocclusion contributed to or caused by airway obstruction or intercepted early, then orofacial growth could be normal. But plan on 2 phases, an interceptive phase followed by a phase of fixed orthodontics, probably with an orofacial or dentofacial orthopedic device. Then we rebalance what nature started out poorly, or genetics may have. In Atlanta, where I live, I've looked over and over and over again at why I was seeing these problems. And what I found was that tonsil adenoids are just a small part of it. Most of the problems are in the nose, from deviated nasal septums, allergic rhinitis, nasal polyps, and chronic sinus problems. For each of y'all out there practicing, remember, if you suspect this, get a good medical history, get a good history from the parents, look at the teeth, look at the child frontally, and then decide, do I need to go ahead, look at the throat, can they breathe through what they've got in there? And then refer to the orthodontic specialist and or his team of specialists or yours, the allergist, the ENT physician. We often end up there. One of my pet peeves has been too, since the nose is a large problem, is nasal hygiene. Remember, the nose humidifies, warms, cleans, and sterilizes the air. So that filter is really important. At home in the air conditioners, you can change the filter, but you can't change the nasal filter. But you can wash it out. These are two products I use. I have no interest in them except for taking good care of my patients. You can mix up your own if you'd like with a little distilled water and salt and put it in the bottle of your choice. This is the way I feel about nasal hygiene, rinsing it out and washing it out as opposed to medicated care which dries out the nose. That would be the antihistamines and the corticosteroids. It's like in Georgia, when the yellow pine pollen's out, if I take my car every time and I put it in the garage and keep it dry, I drive it the next day, all that's going to happen is more pine pollen is going to build up on it. If I wash the car, then I take care of it. Otherwise, it's like you're driving that car all the time. So your health's going to be sacrificed because you dried it out. The nose is the moist place. So how do you tell your patients? Hey, how do you help the moms get the picture? First, you do a little exercise that I showed you earlier about exhaling. Take a deep breath, exhaling, close your lips, pinch your nose, and swallow. And let them feel the suction. They'll get it then. Ask them, can you eat and swallow with mouth closed? Ask them how they breathe at night. They will probably have to develop a history in this day and time to get insurance coverage or have sleep disturbances. So get that history, get the parent involved. And I guess if you really wanted to understand, and I'm not recommending this, what sleep apnea is like, go get the nasal pinch that they the swimmers use, put that on your nose and try to go through a day with it. See how that would feel. That's what sleep apnea and total obstruction is like. So the secrets of airway obstruction will be slowly revealed to our dental professionals. It's not going to be an easy trip, too multifactorial, too variable. But the dentist and his team and the team of medical specialists, we will become the gatekeeper of general health and the health of the orofacial complex. And we'll improve the well-being of all of our patients. Not only can you save a smile now, you can save a life by early recognition and treatment. And you can even help someone who is suffering with it later in life. So I hope this information stimulates you to look more into orofacial health, airway obstruction, and develop a better treatment for your patients. Our goal is to assist the patient in creating a healthy smile and bite that grows and ages appropriately with the face and enhances overall appearance, health, and well-being. Thank you for your attention.
You had one question for you?
Okay. Yes.
Questions, I'm sorry.
There's only one technology too that can help you visualize the airway in its entirety, and that would be a CBCT like the 9600. The 9600 provides so much more information throughout. I routinely go through I go through the nasal, through the teeth, through the nasal passages, all the way from the top of the head, the bottom of the head, and in and out, and all the way down the throat to better assist my patients in preventing their life from being altered by airway problems. The next question was, you know, was the 30 millimeters, would that be an indicator to take the CBCT? I think if I'm a general dentist, if I'm below 30 millimeters, that's when I need to make sure I get the referral to somebody who has a technology that can take the CBCT and work from there to determine what the diagnosis and treatment should be, again, with their team of professionals. So take that 30 millimeters and work with it, and I think you'll find that that's not the golden rule, but that's one of my rules. And remember too, if you don't have a Bowley gauge, then a cotton roll is about 35 millimeters. I hope that helps, and I hope you've enjoyed the presentation and my quest to try to solve some of the problems associated with airway obstruction.
Thank you, Dr. Dunwoody. Give you a little.
You're welcome.
So, I'd like to thank everyone for joining us today. We couldn't have done this without you. If you'd like to learn more about our technology or the technology you saw today, please visit carestreamdental.com/virtual trade show. I'd also like to thank Dr. Polly, Dr. Dunwoody, Juan Alarcon, and Matt Greer for coming in and providing their expertise today, as well as the video content provided by Dr. Rick Ferguson, Dr. Lester Gill, Dr. Michael Picos, Dr. Rico Short. In addition, a big thanks to the Carestream Dental team for pulling this off behind the scenes. The world is changing, and over the coming weeks, we'll introduce other new ways that you can interact with us, and even new ways you can interact with your patients. I'm excited to be the first to share that Carestream Dental will be rolling out a teledentistry solution so that doctors can meet remotely with patients. Visit carestreamdental.com/teledentistry to learn more. I know that many of your practices have been affected by this global health crisis. Maybe you're bored at home right now because you can't go into the office. Maybe you're concerned about your business. Maybe you're worried about how your elderly patients will get the care that they need. We share your concerns. We want to partner with you during these unstable times, and I'll say it, scary times, but we've learned that people are creative. Just look at how our team came together today and built this online trade show. I know you're finding creative ways to still connect with your patients while keeping them safe. Most important, people are resilient. We'll get through this together and support your practice no matter the situation. Thank you for joining us today, and have a great Friday and the rest of the weekend. Good job, team.